Malignant disease in the breast begins entirely out of sight. A small cluster of abnormal cells multiplies and violently expands into the surrounding healthy tissue long before it is large enough to be felt. By the time a patient notices a physical change, the disease has already established a foothold. To safely identify and manage these masses, every single breast complaint must be evaluated using a strict protocol known as the triple assessment. This flowchart outlines the process. 3 distinct steps: clinical, radiological, and histopathological, executed in a specific order. The sequence is non-negotiable. The physical findings dictate radiological imaging. The radiological results then pinpoint the target for histopathological extraction. You cannot skip a step or reverse the order. Mastering this algorithm requires understanding exactly why one step mandates the next. You have to connect the mechanical failure of anatomical structures to the physics of radiological imaging, and finally to the standards of tissue extraction. Strict adherence to the sequence is the only way to rule out malignancy without creating diagnostic blind spots that put the patient at risk. The breast is a modified sweat gland. To examine it accurately, you first need to define its standard macroscopic boundaries. Vertically, breast tissue spans from the 2nd to the 6th rib. Horizontally, it stretches from the midline of the sternum to the mid-axillary line. There is also a distinct extension of breast tissue that travels upward into the axilla, known as the tail of Spence. This is a clinical trap. Sensitive to hormonal changes, the tail of Spence can become physically prominent and mimic a pathological axillary lymph node. When an abnormality is found within these boundaries, its location must be standardized before any imaging occurs. This is done using the clock face method. Precise anatomical mapping and standardized spatial documentation form the required baseline. Radiologists use these exact coordinates to calibrate their search. Look at this cross-section. The breast's shape is maintained by suspensory ligaments of Cooper. Infiltrating tumors contract, pulling the surface inward, creating skin dimpling. This is an exam trap. Because this is purely mechanical tethering, dimpling does not indicate actual skin involvement for cancer staging. Centrally, 9 to 12 lactiferous ducts open at the nipple. Benign duct ectasia causes a slit-like retraction, but an infiltrating carcinoma creates a distinct circumferential pull, retracting the entire nipple inward. Poda orange has a different mechanism. A tumor obstructs superficial lymphatics, causing severe edema. The swollen skin bulges around anchored hair follicles, creating deep pits. Unlike dimpling, Poda orange is a sign of direct skin involvement. If this edema covers more than 1/3 of the breast surface, the diagnosis immediately shifts to inflammatory breast cancer, one of the most aggressive forms of the disease. Structural mechanics dictate the clinical presentation. A thorough physical exam allows you to predict microscopic tissue involvement based purely on the geometry of the skin. To trace the potential spread of that disease, you have to map the lymphatic drainage. This diagram shows how surgical staging is determined. Axillary nodes are strictly classified by their spatial relationship to the pectoralis minor muscle. Level 1 nodes sit lateral to the muscle, Level 2 are directly behind it, and Level 3 lie medial to it. There is also an interpectoral group known as Rotter's nodes, trapped completely between the pectoralis major and minor. To avoid the severe complications of removing all these nodes, a full axillary dissection, surgeons locate the sentinel lymph node. This is the very first node to receive drainage from the tumor. If it is free of cancer, the rest of the axillary basin is typically spared. Axillary mapping is entirely relational to the pectoralis minor. This geometry dictates the aggressiveness of surgical staging. In the radiological phase, the choice of initial imaging is governed entirely by patient age. Baseline protocols separate sharply between women under 40 and over 40. This grid illustrates the density paradox for women under 40. Dense glandular tissue appears white on X-ray, just like breast cancer. As seen on the left, mammography on a young breast completely camouflages the tumor. Ultrasound is mandatory. For women over 40, dense tissue is replaced by fat, which appears black. This dark background allows a white tumor to stand out clearly, making mammography highly sensitive. A standard mammography requires 2 angles, the craniocaudal, or CC view, from top to bottom, and the mediolateral oblique, or MLO view. The MLO view is critical because it is the only angle that fully visualizes the axilla. The radiologist is hunting for specific calcification patterns. Large, popcorn-like macrocalcifications generally indicate benign disease, but tightly clustered microcalcifications strongly signal malignancy. Patients are even instructed to avoid applying talcum powder before a scan, as the calcium salts can create artifacts mimicking dangerous microcalcifications. If an ultrasound is used, the geometry of the mass is the primary indicator. Benign lesions tend to grow parallel to the skin, making them wider than they are tall. Malignant lesions invade aggressively upward and downward, making them taller than they are wide, often accompanied by suspicious lymph nodes that have lost their normal fatty hilum. Radiological physics must perfectly match the patient's biological tissue density. Using the wrong modality guarantees fatal false negatives. While ultrasound and mammography cover the baseline, breast MRI is deployed strictly for specific, complex indications. It screens high-risk genetic mutations, evaluates inconclusive ductal lesions, and defines spatial spread of cancer. Specifically, MRI distinguishes between two patterns of spread. Multifocal disease involves multiple tumors confined to the same quadrant of the breast. Multicentric disease involves tumors scattered across different quadrants or located more than 5 centimeters apart. Multicentric spread typically rules out breast-conserving surgery entirely. MRI is also the absolute gold standard for evaluating the structural integrity of breast implants. This scan demonstrates the classic Linguini sign, wavy floating lines confirming an intracapsular rupture, where the implant collapses but the outer fibrous capsule remains intact. If using ultrasound to check an implant, that same intracapsular rupture will show a stepladder pattern. If the silicone leaks outside the fibrous capsule entirely, an extracapsular rupture, the ultrasound will show a dense, chaotic snowstorm appearance. Advanced MRI imaging isn't for routine screening. It is a specialized tool deployed exclusively to navigate complex anatomical disruptions or extreme genetic risk profiles. No matter the imaging modality used, findings must be translated into an actionable surgical plan. This is done using the Breast Imaging Reporting and Data System, or BI-RADS, a universal lexicon standardizing communication between radiologists and surgeons. This scale ranges from 0 to 6. Score 0 means incomplete, requiring additional imaging. Scores 1 and 2 are negative or benign. A BI-RADS 3 means probably benign, carrying up to a 2. When a radiologist assigns a score of 4, low, moderate, or high suspicion, or a score of 5 with greater than 95% malignancy risk, the protocol locks into a strict mandate. Biopsy is required. The BI-RADS system successfully converts subjective image interpretation into a rigid, objective, algorithmic surgical trigger. Once a biopsy is triggered, the surgeon has to physically extract the tissue. The vast majority of epithelial breast cancers originate in a highly specific functional unit called the terminal duct lobular unit, or TDLU. For decades, surgeons used fine needle aspiration cytology, or FNAC, to sample lesions. But FNAC is functionally obsolete. On the left, FNAC extracts scattered individual cells. On the right, core needle biopsy extracts an intact structural lattice of tissue. Without that architectural lattice, FNAC cannot tell if a cancer is invasively breaching the basement membrane. Isolated cells also fail to reliably register vital immunohistochemical markers like estrogen receptors, progesterone receptors, HER2, and Ki67. Cytology, which only provides loose cells without structural architecture, is diagnostically insufficient for modern oncological treatment planning. You need the tissue structure to define the disease. Preserving that critical tissue architecture, the 14-gauge core needle biopsy is now universally classified as the investigation of choice for any suspicious breast lump. It secures enough material to confirm the diagnosis, grade the tumor, and run complete receptor profiling. This introduces a fascinating clinical paradox. Technically, removing the entire mass, an excisional biopsy, is the absolute gold standard for definitive diagnosis. But performing the gold standard as your first step is heavily contraindicated. If you blindly excise a lump that later turns out to be invasive cancer, you have compromised your surgical margins. You've ruined your ability to accurately map the axillary lymph nodes. The patient is now guaranteed to require a second definitive surgery. Other methods serve minor, specific roles. Vacuum-assisted biopsy uses thick probes to cleanly remove selected benign fibroadenomas without open surgery. Punch biopsies are reserved for superficial skin presentations, like Paget's disease of the nipple. The investigation of choice prioritizes comprehensive preoperative staging. You never extract the mass until you know exactly what you are extracting. Let's run a final case through the entire logic engine. A 42-year-old patient presents with a firm mass plotted at the 2 o'clock position. Because she is over 40, her glandular tissue is less dense, dictating mammography. The scan reveals tightly clustered microcalcifications. The radiologist interprets those calcifications and assigns a BI-RADS 4B, moderate suspicion of malignancy. The algorithm strictly demands tissue. The surgeon bypasses FNAC and performs a 14-gauge core needle biopsy. The intact tissue lattice confirms invasive ductal carcinoma, securing all receptor profiles while leaving the axillary pathways undisturbed for accurate sentinel node mapping. By following the sequence, 3 major clinical traps were avoided. The physician didn't mistake skin dimpling for late-stage skin involvement. They didn't order a blind mammogram on dense tissue, and they didn't jump straight to a blind excision that would ruin the patient's surgical options. The triple assessment is a rigidly constrained sequence. The clinical exam sets the target, the physics of imaging reveal the structure, and the core biopsy confirms the pathology. It proves that in breast surgery, disciplined adherence to the algorithm outranks clinical intuition every time.